Thanks for attending. It's a bit of a different meeting today, and that's what the topic of today's session is about. So we've obviously had a lot of things change in the world lately, and uh, for people with medical conditions and chronic illness, I think there are particular challenges. So I wanted to discuss a few things that have happened in our clinic, um, get some idea of how things have affected the people in the meeting now, and hopefully touch on the questions that you had wanted to have answered or at least explored today. So I'll move on to the next slide here. Um, I'm going to state the obvious, which is that the Parkinsons Society BC has been very helpful in this time, and I have directed a lot of people to their website for supports and services. And I still think that it's a great resource access point for people. We did have some interest in exercise programs and things that were online, and those things have been collated very efficiently and as I mentioned in the title talk, nimbly. So I encourage you, if you haven't looked there, to look. Obviously, I'm preaching to the choir somewhat. The slide is intended to show a sign with an obvious message, because this is somewhat of an obvious message to anyone in this presentation. Anyhow, as a warm-up, I wanted to try and pull the group. Just checking the chat. I hope, Joanne, the audio is better now. Please let me know if it's not the case. And the warm-up pertains to a bit of a poll. So this is a bit of an experimental thing here. We're going to try and do a poll. And this poll is something you can get onto from a web browser in the screen beside the presentation. There's a link in the chat to the poll. And when you click that, you'll have a screen show up to add a response to the poll. And we should see the responses fill in live, which would be kind of cool if it works. Okay, so it seems I've clicked through and it says it's giving me a message as well. I'm going to try and troubleshoot this on the fly here so we get it going. If anyone's having trouble with it. Let me see here. It should be live. Let me see if I can do this in a different way here and just activate the poll. I know it's not working right now. If that's so, I'm going to try and get it going here. I think I should be able to do that. Let's see. Present. Okay, well, we might have to do a straw poll if it's not going to work. Okay, well, yeah, I'm not sure why it's not working here. So, all right. this is actually maybe a good demonstration of some of the challenges of the COVID-19 era. Because we're presenting this in a platform that I think is not activating the poll content. Okay, now it's active, I think. I hope. I had to activate it by presenting it in a separate presentation, but I think it should now work. So I'm going to click my location here in Kelowna, where I'm presenting from, and I think it's probably just not refreshing the live view of the results, because I can see it on the other presentation. Okay, that's interesting. So I'll share the results of this at the end if I can figure out a way. We've got a smattering of people on the island. We've got a smattering of people in the Vancouver area, and some around the Okanagan and East Kootenay region as well. So I can see your responses, so please feel free if you are comfortable with doing the poll to go ahead with it. We've got someone out in the ocean as well, which is kind of fun. Great. So I'm going to move on to the next slide, which is another poll slide, and we'll see if we can collect some responses from there. The poll should stay active through the whole presentation, so you can respond, and I'll tell you the responses at the end. In a quote-unquote usual presentation format, we would probably see the responses live, but such is the nature of the COVID-19 pandemic. So rest assured, I can see your responses. So I'm curious to know who's attending the talk, if it's mostly people living with PD, people living with conditions that are related or similar to PD, or if you're attending as a support person or someone in advocacy or healthcare, or if you have a friend or loved one living with one of these conditions. And although it's not showing live, I'll just tell you, so far we've got 33% of the respondents are people living with PD. We've got an even split of otherwise people in healthcare advocacy and support, or with friends or loved one living with PD or a condition like PD as well. I wanted to see in general how people feel their medical care of Parkinson's disease has been during the COVID-19 pandemic. And this is on a 5-point frown to smile scale. And I'll kind of give some live updates on this for a few seconds, then we'll move on to the next poll item. But I think for most people, there's probably at least a neutral or slightly negative impact of COVID-19. I would be very curious to hear if anyone has noticed any positive aspects of how the pandemic has affected their medical care. I think it has opened some doors, which is part of what we'll talk about today, for ways to improve clinical care, and in particular care for people in rural or remote areas living with Parkinson's disease. But those things may take a bit of elbow grease to get working right, as I've demonstrated for you here live. So feel free to respond to that. And the second question with that is, how has your non-medical or self-care, including being able to maintain physical activity, maintaining connections with people who are caregivers or support persons, how has your self-care been affected during the COVID-19 pandemic? And I'd be curious also to know if people have positive or negative experiences that we can share and learn from somehow. So as you're responding to that, most of the responses for medical care skew either neutral or slightly orange frowny face. And the same seems to be true of self-care thus far, but I'll leave those polls open. The next thing is a free text response for you to indicate what has been your biggest health concern in the last few months. I'm curious to know because I ask this question every time I present to a group of people with Parkinson's disease to get a sense of what the undercurrent is in the community and what people are concerned about, what therapies are of interest, and how we can stay current with what's of interest to you. I'll leave that open for responses, and I'll just move on to the kind of more directive part of the presentation. So I'm going to talk about is how access to neurological care is different in different parts of the country, and in particular in BC. And I want to first reflect on how virtual care and telemedicine might work in different neurological conditions, and how Parkinson's disease fits into that spectrum, and how we can actually adapt and use these technologies to better suit people with Parkinson's disease. And also reflect on how priorities have changed for people and for doctors caring for people with Parkinson's disease and other healthcare workers, and what challenges people have faced. So I'm hoping we can do a hearty, healthy Q&A portion as well, and look at some solutions to those challenges. I'm just going to scan quickly the chat, and I find that people are quite comfortable working with the chat. Please don't worry if you're not able to access the poll. It was kind of just an icebreaker, and it seems that I've broken the ice in unexpected ways here. So we'll address some of the comments as well. I appreciate if people are adding their experiences, and I'll try and refer back to them individually. So I wanted to show you this figure I made through some data from the Public Health Agency of Canada. This represents the regional prevalence, meaning how many people are living with Parkinson's disease in different parts of the country. So on this figure, don't worry too much about the absolute, like what the numbers actually mean here, but the all of Canada line is the red dotted line. I'm going to show with a little arrow here on the screen. So this line here is all of Canada, and up here we see Ontario, what the prevalence is in Ontario, in Quebec, and in the Maritime provinces over the years. So you can see that there's been a bit of fluctuation, but in general, if you look across Canada, the trend is a slight increase in the number of people living with Parkinson's disease. If we look at some other regional information, the data for British Columbia, which is here forest green with some trees at the icon section, it somewhat parallels the Canadian data, as does the data for Alberta and the Prairie provinces. So no surprises there. If we look at the Okanagan, where I live and work, and see people with Parkinson's disease, it's overall about the same, maybe slightly higher in certain years than British Columbia as a whole, but it tracks fairly well. So suffice to say, there are a lot of people in British Columbia with Parkinson's disease. This is the data from now a couple of years ago from the BC Centre for Disease Control, which no one had heard of until a few months ago, and now everyone is aware of, which is great. So you'll see in Northern Health, there are about 500 patients living with Parkinson's disease at that time from the provincial data. And this information is gathered based on prescription information without reference to who the individuals are, but how many people are prescribed medicines for Parkinson's disease. Somewhat the diagnostic codes that are submitted to the medical services plan when people see doctors. And some other sources, they kind of roll it in together to determine where people are living with Parkinson's disease. So it's actually a very helpful set of information, and it's available to the public. So in British Columbia, as of that time, there were about 13,100 people living with Parkinson's disease in the province. So it may come as a bit of a surprise. Fraser Health was the leading sub-region in the province. It may come as a surprise unless you live in Fraser Health, where I think it would not be a surprise. Sorry, that's not COVID cough. This is what you call a COVID excuse when you accidentally have something stuck in your throat and it leads to a cough. Vancouver Coastal Health, and here where I live and work in Interior Health, we have about 2,400 patients or people living with Parkinson's disease. If we looked at the neurologist distribution in the province at that time, which I did because I was interested in this, of course, it might not be a surprise. Most of the neurologists are located around the Lower Mainland and somewhat on the island. Here, the size of the brain icon does not indicate quality, but it indicates quantity. I'm just saying. But you can see there are large swaths of territory in this province where there are very few neurologists. If I redrew this now, we'd have a slightly higher number in the interior. We've had a few more neurologists recruited there. However, the neurologists who are specifically trained in the subspecialty care of Parkinson's disease and movement disorders are a much smaller and still more focused group focused around the Lower Mainland. So one of the things I think is important when we have a large number of patients distributed across a very large area. So the interior itself is like the size of France, basically, with 1 million people in it. We need a strategy that addresses issues for people all across the province for care of Parkinson's disease. So, of course, where I live in the interior, it's a drum that I'm happy to bang, and I think it's an important concept. And there's a debate, as in many areas, of centralizing or decentralizing care and resources. So what are some of the challenges we have in applying that in Parkinson's disease? Well, before the COVID era, there were some attempts to use telemedicine to solve this problem. And the tricky parts are Parkinson's is complicated. It's a difficult thing to figure out what the treatment should be. And it really depends a lot on our neurological exam. So assessing people's tremor, their stiffness, their slowness, if they have unwanted extra movement. And when we see people, of course, as you all well know, we see people at a certain time of day, and your symptoms and problems may be vastly different from hour to hour during the day. And so we have to take a little snapshot of how someone looks on examination and then really get to know how that fits in the context of someone's story. If people are saying their symptoms are fluctuating a lot in the day and up and down, then we kind of have to imagine somewhat what that would look like to decide on treatment plans. There's an extra layer of difficulty when we can't examine certain things like stiffness, which are hard to do over a video screen. So with those challenges in mind, and this challenge which I've mentioned here, how do we take a 30 or 60 or maybe less snapshot of someone at some point in the day and guess kind of how they're doing throughout the day when they may be riding a bit of a roller coaster. Shifting now to where Parkinson's disease fits in other neurological conditions in telemedicine, the way I've thought about this in trying to approach the problem is on this two-dimensional scale here. So this is like, you're back to science class in high school with the graph paper out. But I think you can think of how we look after neurological patients from urgent problems to not so urgent problems, and from things where we really rely on the physical exam and where we find the exam is limited over a video conference, to things where for the decision we're making, a video conference is adequate to make the treatment changes. This is how I've kind of thought about this. And if we think about different neurological conditions, something like acute stroke, where someone has a sudden lack of blood flow in part of the brain, and we have to examine them and make a decision very quickly about whether to give risky but potentially brain-saving medications within minutes. It's in most cases a good on balance way to make decisions to sacrifice some of the high fidelity of a face-to-face examination for the benefit of making an urgent decision. So I'm on call for neurology here in the interior now, and So I had a call yesterday for a patient with an acute stroke um, about 100 kilometers away from here, and we were able to go through a quick examination over video and make a stroke treatment decision for that patient. Whereas for a problem that's been going on for months or years, which is a bit finicky, for which our treatment decisions really rely on the examination, it might not be okay just to go onto a video conference and try and decide how to approach it. It might benefit from a little bit more information applied in addition to a video. So that's the way I've kind of approached this problem here in the interior. So Telestroke or telemedicine is widely used in stroke neurology, as I've just described. In headache, there's been some interest in using telemedicine as well. And I, in particular, was interested in this study where it's kind of a faux pas to show graphs and abstracts on a presentation, but suffice to say, what these authors did is they looked at patients with headache seen over a video conference in their clinic versus seen face-to-face in their clinic to try and compare, can they do as good a job with headache treatment for patients with long-standing headache problems. And they found that they could. Probably most of the time, maybe not always, but most of the time. So going back to this model I described to you of Parkinson's disease, the idea would be it might be possible to split Parkinson's disease into different little subclouds here. So there are people with Parkinson's who mainly have balance problems, people who have cognitive problems, people who have a lot of unwanted extra movement or tremor, and those people might have different needs in terms of a virtual care examination. So I'll come back to that in a second. When we talk about examining people with Parkinson's, it's really something like changing your guitar strings. You get a bit of a brighter sound to how they sound, or if you listen to a very nice Steinway piano or a bargain basement dollar store keyboard, you'll hear a lot of difference in the texture and quality of sound, even though the note is the same. So that's called timbre. And so there's a lot of this texture and fine grained information that's sort of hard to put your finger on, that might be lost when we go from a face-to-face assessment to a virtual care assessment. So I'm interested in reducing that gap. So I had a student here who did this study, Dakota Peacock. He's nearly finished medical school now, and he did an assessment of the needs of telemedicine for Parkinson's disease by doing focus groups. So what we learned from that was a couple of things. So it was a small number of people we had respond to this, but this is well before COVID. We had a lot of patients who said that they occasionally, sometimes or often, or always even, avoided appointments certain times of year with their neurologist because of travel. This is for people in the interior, and it might differ in different parts of the province. And then a lot of our patients here in the interior also felt that to get the best care for their PD, they needed to live in a larger center, an urban center. So that is somewhat troubling to me, from considering where I live and work. And then we found a lot of people said that they would be comfortable trying to use video conference technology for follow-up care. So this background map now, if you're still with me, I see people still in the conference, so I assume people haven't all left or fallen asleep. This is a heat map from where patients reside that travel to our clinic. So out of the last 400 or so patients, where do people reside that we've seen in our clinic here in Kelowna? It's all over the place. So we have a smattering of people, mostly around the Okanagan, and somewhat in the South Interior, and even the southeast part of British Columbia. But a few people, mostly I think people who have moved from here out to Vancouver or the island, have come back for follow-up appointments as well. So taking that context and applying it to our patients, we decided to do a clinical trial where we were going to look at, can we do as good a job for certain patients and certain problems face-to-face versus over video conference. And we did that with a fancy tool to track tremor or dyskinesia for people they take home for 3 days between appointments. So this is actually a device that you can use. It's a Health Canada approved device for monitoring symptoms in Parkinson's disease. It's now probably 5 or 6 years old, and it's basically, it looks like a sort of prison bracelets, I guess, but you're not under arrest. It's supposed to help you. So it's supposed to track on your more affected side what times of day you have tremor and dyskinesia. And here, this is an example graph of what the information would look like. So tremor here is shown with this black line. And for this example participant, there was tremor seen when they were wearing the device at certain points in the day, kind of up and down. And here, dyskinesia was seen mostly at times that were not the same times as tremor. You would imagine that they probably aren't occurring at the same time, and perhaps in this window it was misreading it. But the idea with this is maybe we can get a better idea of what's happening through the course of a day or several days to add to a snapshot of a video conference exam. So we use that system, and we compared it with this nice sheet, which you may have seen before. This is what's called a Hauser Diary, or a Parkinson's Disease Symptom Diary. So a lot of clinical studies and some clinics will use this for trying to get a sense of what happens with patients through the day. On this, if people feel their mobility is ideal, then they would fill in an X through the hours of the day on the 0 line. And if they feel like they're over-treated and they're having unwanted extra movement, it would be tracked on this line above. So this is towards what we call dyskinesia, or unwanted extra movement. And then down on the lower scale would be if you feel you're stiff, slow, or frozen, or you're under-treated. And so we asked people to do this for 3 days to try and get a sense every hour of whether they were too hot, too cold, or just right, like Goldilocks and the Three Bears. And if people had tremor, because not everybody does, we asked them to also indicate here if it was mild, moderate, severe. And for people with dystonia, they could indicate that here too. We tracked, this can end up being a legal sized piece of paper for some patients, but we had medications here as well on the list, and they would mark down when they took their medications. And so I find this is actually a good tool if people don't have a good sense, if they're fluctuating, like if there's a pattern to it. We can look at this tool and say it looks like every day around the same time you either have a little bump in the tremor severity a certain time of day or around that time, and then we can look at what's happening with the medication doses before that, and can we adjust it to try and optimize a bit. So this is kind of the old-fashioned way of doing it, and then that sensor thing that I showed you on the previous slide would be a more automated kind of high-tech way of tracking tremor and dyskinesia. And so we were doing this to try and blow the cloud over across to the other side is what this is intended to represent here. So maybe we can take some of the sub problems that we see with Parkinson's disease and split them into things that are maybe more adequately assessed with telemedicine if we apply some different tools. So I thought that this would work best for people with tremor and dyskinesia. And so that's what we studied. We studied people who had their primary concern was improving their treatment of tremor or dyskinesia. And we randomly said, okay, we'll do face-to-face follow-up with the symptom diaries, that sheet with the hourly X marks, or the virtual care with the automated sensors. And so we were doing this ticking along, trying to get to about 40 patients. And then COVID happened. And ironically, we could no longer continue the study because it was not ethical or feasible or practical to see people face to face. So surprisingly, we could only do the virtual care style of care once that occurred. And many of the clinics in the province halted patient visits around the same time. We I think went from March until sometime in late May without having any face-to-face encounters. So we ended up having to stop our study for that reason. And long story being short, we're working that up right now, but it looks like it's not worse to do the virtual care, which is what I was hoping to find. So I might just scan the chat at this point to see if there are comments that have come up here that I can respond to. Okay, so missing exercise and swimming. Definitely, I've heard that a lot. A lot of people were doing fitness and exercise classes and group things that were no longer occurring or feasible, or maybe they'd closed for good, which was a huge loss for people. Core stability, I think that relies a lot on some of those exercise and activity things. Medication adjustments, I agree. And so I think the challenges with medication adjustment are, from my perspective anyway, for the reasons I've just discussed, but there might be other reasons I'm not attuned to. Orthostatic hypotension. So Roy, you raise an important point, I think, as well. A lot of the management of non-motor symptoms is done sporadically as it is, and measurement of blood pressures laying and standing, I think, is something that probably happens only in the movement disorder clinic or in cardiology clinics, and sometimes in primary care clinics as well. But it's a really important thing for people who get lightheaded times in the day, and I think for a lot of people, blood pressure is just not being measured lately. Primary health concern, exercising at home, yep, same thing. Depression, yeah, so I sympathize with that. I think that the mental health effects of COVID-19 are particularly pronounced for people with some chronic illnesses, and maybe with a risk for social isolation. Exercising and working out, program for daily exercise, local gym. Yes, I'm hearing a lot of the same kinds of themes here, but thank you for the comments. I'll try and return to the comment field later in the presentation. Okay, so the major impacts I've seen have to do, I think, with dystonia, which is unwanted twisting or turning or stiff movements of an area of the body. Because sometimes those are treated with injections, and we can't do those over the video screen. The other thing is new consultations. I have been quite reluctant to conduct a new consult appointment over a virtual care platform for some of the reasons I've outlined. For me, the first time I get to know a person with Parkinson's, I need to feel the muscle tone, and it might be possible to make inferences about the muscle tone over a video conference when I've already checked it before. I think it's really difficult to do so without putting it together with reflexes and things that we usually do when we see a person the first time. It's tough to do the first assessment over video. So I've found that our waitlist has certainly not gotten any better in the last few months. Patient support groups and support services, as I mentioned, have been quick to respond. We had two kinesiology programs here that were doing exercise classes moved to a virtual platform with Zoom, and they're, I think, listed on the Parkinsons Society website, so I don't want to give any specific plugs, but we found, I also got contact from across the country about different providers who are doing that with virtual exercise programs. That may or may not be your cup of tea, though. A lot of doctors, primary care and specialists, have continued trying to conduct appointments through virtual care and phone appointments. Whether or not that works as well as intended is a different story. And the health authority, at least here, has very rapidly mobilized to support virtual care tools in the interest of trying to limit presentations to the emergency department, particularly early, when there was a high degree of concern about a wave of cases flooding the hospitals and overwhelming the intensive care system. So I think there's been some lessons learned from that. When we started doing virtual care visits, I took some polls from people who participated, just asking kind of how's it going, what can we do better with. And so we had a bunch of people respond that had appointments, and basically they told me that it sort of was okay and they had some concerns about it. So in most cases, I think people found that they were able to get a clear treatment plan from the appointment, out of this sample anyway. There was a not insubstantial number of people, though, who felt that the plans or the management was affected by the pandemic and by the method of assessment. And then looking at what people would prefer, most people would still like to do a face-to-face visit. And this is, again, this is a small number of people who did do virtual visits. I think probably the numbers, if we poll everyone face-to-face about this, would be skewed much more towards people preferring in-person care. On this platform where we're doing a virtual care presentation, I think we've got probably a more enriched, tech-savvy group of patients and people with Parkinson's disease. So I think in general we have to remember that we need to serve the whole population of people with this condition, and there's certainly a risk of some people being overlooked if we only play to the tech-savvy crowd. Some comments I got, so that I highlighted some aspects of them that I thought were useful. So follow-up care, people thought, okay, that's great. I'm glad I've seen you in person before. We used the virtual whiteboard a couple of times. That was kind of fun. Privacy concerns, I think, are really under appreciated and under recognized in this era. And people, especially at the height of the initial first surge of cases in North America, kind of threw privacy protections out the window in some cases with some actions. I think in healthcare there was an appropriate degree of caution in most cases and most settings. However, there's still, when you're on a virtual care visit, someone walks behind you, or something else is visible on the camera screen. Or you don't want people in your house, so to speak. Privacy concerns are a real issue. And then, as I've mentioned before, so there are people who are technically challenged, so to speak. This is, I'm not putting words in someone's mouth. This is what they said. Some of our generation can be technically challenged. Well, as I've demonstrated to you, I also can be technically challenged at times here because I thought I was all slick and ready to go with those polls, and it didn't work. So there are always going to be issues, and I think that highlights the need for patience and understanding. So after doing this for a few months and having resumed some face-to-face encounters and still doing much more virtual care visits than we had before the COVID-19 pandemic, my observations are that most of the tools that are used are business conferencing tools and are not optimized for medical care. The issues with bandwidth and connection are important when I'm looking at a tremor, for instance, that might be going 4 or 5 times a second. If I'm only getting 5 or 10 frames per second, you can't really assess that very well. The other thing is people have different setups. It's quite varied. And so in our clinical study, we specifically did this in the clinic because we had the same camera system and setup, and we had a very high quality data connection for every visit. So there was not as much an issue with the varied connection quality and equipment issues with different people from home. One of the things that's often frustrating from our end is when trying to examine things, if we can't see them because they're out of frame. And walking in balance I found particularly tricky in that sense. It's really important to have support staff who are ninjas with setting things up, because otherwise it's frustrating for all people involved, I think, with virtual visits when the connection is not working. And there are things that might on the face seem maybe not the best for virtual care. And what my experience has been is that those things, when I have that spidey sense tingling, almost always requires another appointment face-to-face when it's feasible. So those are some of the lessons I've learned. We've